Yes, it is.
Good evening. Thank you for the opportunity. I must thank Dr. Vineet and the Singapore Urology Association for inviting me to give this talk. So the talk today is about oligometastatic prostate cancer, and I would be failing in my duty to, if I didn't mention the slides that you're about to see. Probably a part of it is from Dr. Gagan Kautam. So what is oligometastatic prostate cancer? I think it's reasonable that we touch upon that first. It was a concept that was, am I audible? Is it okay?
Yes, we can hear you loud and clear. No worries.
So it was a concept that was initially proposed by Hellman and Weisselbaum in 1995. And it was based on their clinical experience. And if you look at the Hallstadian theory of metastasis, where you had the tumor, from there it went to the nodes, and then went on to blood spread. And then you had the systemic hypothesis that said as soon as the malignant cells moved out of the organ, it became a systemic disease. So oligometastasis is something of an intermediate state. And why is it so important to us? And the reason it's important to us is because is it a potentially curable entity? Or at least does it offer a superior cancer-specific survival when you compare it to the polymetastatic state? That's why we are interested in it. And that's one of the reasons it's garnered so much attention in these in the recent past. Sorry. Right. So in oligomets, if you look at it, has the dogma changed? 10, 15 years ago, it was all relatively safe for us in terms of, intermediate and low risk disease would be treated with prostatectomy, and towards high risk, you would go into irradiation, and then metastatic disease would be treated with hormone treatment. That dogma has slowly been changed. We have lessons from other solid tumors, colon, for example, kidneys, for example, ovarian tumors, for example, where they've all shown that treatment of the primary per se had a beneficial impact on the patient's overall survival. So is that applicable to the prostate? That's the question here. And oligometastatic disease, does it play a part in this? So if you look at this diagram here, you have localized disease where you have surgery and radiation. And as you go toward polymetastatic disease, it's more of systemic treatment. And if you think oligometastatic disease is somewhere in between, it's a distinct disease entity, not just one step in the continuum, then there is a definite case for treating the metastatic elements as well as the primary tumor to give the patient a better survival benefit. So, biology of oligomets and what criteria do we use to define oligomets? Now, what we've found over a period of years is when you do a microRNA analysis between oligometastatic disease and polymetastatic biopsies from the metastasis, you see that there is a definite difference in the polymetastasis as well as oligometastasis. The same microRNA is not present in either of them. And also, when you look at polymetastatic states, you have BRCA positivity, ATM positivity, and the same is not always true in oligometastasis as well. Obviously, there is going to be this is a heterogeneous disease. Even if you call a group of patients oligometastatic patients, some of them are going to behave very well, and some of them, the disease is not going to be as good as we want it to be. So it is a heterogeneous entity, but current evidence is pointing to a state where it is a distinct state where the progress is definitely slow when you compare it with polymetastatic disease. So what is the boundary between oligomets and polymets? Currently, it's somewhere in between 3 and 5 metastases. And why did we come to it? We will look at it. So there are about 3 entities that we need to know when we're talking about oligometastasis. The first is de novo or synchronous metastasis, which means the patient presents to us on day 1 with prostatic cancer with a few metastases elsewhere. Right? That's de novo. When you look at oligorecurrent disease, it is where the primary is already been treated and the patient recurs in a very few spots. And then there's oligoprogressive, where the primary has been treated as well as secondaries, the systemic treatment's been initiated, but the patient progresses in other few spots. So for our purpose today, we're going to be looking at 1 and 2, and maybe oligoprogressive at a later time. So what is the definition of oligometastasis? Why did they come to 3 and 5 metastasis? Initially, way back in 2004, Singh et al. Did a paper where they looked at the metastasis after radiation, the number of metastases, less than 5, more than 5, and did it make a difference in survival? And apparently, and they came down with the number of 5, and it did show a survival benefit at that point in time. So you've always had all of these studies looking at 5 or lower than 5 number of metastases. And initially, these studies looked at bone scan and CTs to identify Mets, but now we've moved along. The way we look at metastasis now is more PSMA PET, choline PET, and so on. But most of the studies that we're talking about today had bone scan as well as CT scans to identify metastasis. So that is a fallacy. So the current guidelines, we look at charted data and latitude to give us an idea. So if it's high risk disease, high volume disease in charted, it's more than 4 metastases, with at least in the bone metastasis, with at least 1 outside the vertebral column or spine, or visceral metastasis. Now, if your patient doesn't come under the high volume category, then he becomes a low volume or oligometastatic patient. Right? So that's where we stand right now. So that's how you identify your oligometastatic patient. So once you have this patient, how do you manage him? There's a 3-tiered approach. One is a local consolidative approach for the primary tumor. And then the second is a metastasis-directed therapy. And third is systemic chemohormonal, which is the standard of care at present. Right? So let me talk about a local treatment of the primary. So what are the principles of treatment? The idea behind it is, if you do an aggressive treatment for the primary, will it improve overall survival? And obviously, when you do a surgical removal of the prostate or RT, it may reduce some of the complications that you have because of either bleeding or obstruction, bilateral percutaneous nephrostomies because of obstruction, clot retentions. These sort of problems can come down. And local treatment also has the potential to delay systemic treatment. So these are probable advantages when you look at treating the primary in a metastatic setting. So is there any evidence for local therapy to the primary in a metastatic setting? And I think this paper has changed the way we view things, way we view metastatic disease. Stampede has made a huge difference. And when you look at the Stampede, when you look at irradiation, has it made a difference? Overall, in the study, it did not show a difference. But when you looked at low volume disease, according to charted criteria, it did make a difference. And survival difference was about 73 versus 81 when you added radiation treatment. So it did make a difference, right? Stampede. And I'm going to show you next meta-analysis, top-cap meta-analysis that looked at both the Stampede and the HORED studies. And the conclusion is, again, straightforward. Radiation did make a difference in radiation did make a difference. Just one second. Radiation did make a difference in metastatic hormone-sensitive prostate cancer with a low volume disease. So again, these are straightforward, straight out of the book, randomized control trials that both gave a similar sort of answer for low volume disease. And that's the reason why it's made it into our guidelines. The current European Urology Guidelines 2020 says offer androgen deprivation therapy combined with prostate radiotherapy to patients whose first presentation is M1 disease, and they have a low volume disease by charted criteria. Again, 2020 guidelines, evidence is strong. Just do radiation treatment for patients who've got low volume disease and present with metastatic. Now, if you extrapolate this, what they've actually said is treat the primary in a metastatic setting in a low volume disease, it makes a difference. But is it only limited to radiation, or can we extrapolate it to surgery as well? Now, again, it could be wishful thinking, but then again, there's no difference when you look at surgery or radiation in terms of intermediate or even high risk disease. But should it make a difference in a metastatic setting as well? So that's the point that we're trying to look at here. There are RCTs in the offering, the trombone study in the UK, and they are already on. But let's look at what sort of data we have till now. Is it really made any particular difference, anything at all till now in terms of whether surgery can be used in a metastatic setting? Okay. So what is the rationale for radical prostatectomy? I think we've been a bit over that. It could improve local control. It could remove the prostate as a persistent source of future metastasis. So prostate produces metastasis, and these metastases cause circulating tumor cells, which again have the potential to repopulate the prostate as well. So if it's out of the body, then that reduces further risk as well. And improved response to systemic treatment. So where are we at present? There's another reason why we can look at removing the prostate. Again, more systemic treatment induces more clonal heterogeneity in the metastatic cells. Then again, when you reduce the amount of systemic treatment, that's again a reason for the reduction in clonal heterogeneity. So if you look at surgical management, I'm going to talk about several papers here, but this is a summary of them. The first paper that I'd like to talk about is the outcome of men in N1 disease. So we'll look at N1 disease, we'll look at M1 disease, and see where we are. This is a paper from Peter Scardino, James Easton's group, and 322 patients, 10-year survival after radical prostatectomy. Around 28% of patients were biochemical recurrence free, and cancer-specific survival of 72%. And the interesting point is the number of lymph nodes made a difference. Less than 3 was the actual cutoff that actually made a huge difference in outcome. Right? Again, a couple of other studies, the Johns Hopkins paper, 30-year experience, definite favorable outcome for N1 disease in radical prostatectomy and extended lymphadenectomy, and a German paper, Seeler et al., again, 75% 10-year cancer-specific survival in an N1 setting and radical prostatectomy. So some of the patients did not need adjuvant treatment, around 1/3 of the patients. So this is an interesting point. What was considered metastasis 10, 15 years ago, now 1/3 of patients who underwent radical prostatectomy and extended lymphadenectomy did not need further adjuvant treatment. So what about cytoreduction in N1 patients? This is what we're interested in. 2 papers. One is by Prasanna Suryakumaran, looking at 106 patients who underwent radical prostatectomy in a metastatic setting. And the overall survival was 88.7 after a median follow-up of 22.8 months. They mainly looked at perioperative outcomes and proved that it is a safe and feasible way of treating metastatic patients. Now, again, just a German paper looked at patients who underwent androgen deprivation and radical prostatectomy with only ADT, and it did have a significant difference of cancer-specific survival, 95.6 versus 84.2 in cancer-specific survival. This came out in 2015. Few other registry data from Hamburg, Munich, as well as the SEER data from Culp et al. So in an N1 state, as well as in an M1 state, there was definite benefit to be had. So prospective study, do we have any? It wasn't a randomized study, but this was from the Martini Clinic. They looked at 43 patients versus 40 patients who had best systemic therapy versus 43 patients who had cytoreductive prostatectomy. And there was no significant benefit of surgery on survival, but it did have the potential to reduce local regional complications. And the drawback of this study was the small number of patients and the shorter follow-up in the CRP group. So, given that we don't have robust data for surgery in a metastatic setting, what is the ideal patient we would look at when we look at surgery? One is a molecular footprint that looks at oligomets. We don't have this molecular footprint yet, but since I've said ideal patient, I put it in. If we get this molecular footprint that tells us this patient is ideal candidate, oligometastatic candidate, then I think it's a good way of looking at surgical removal of the prostate. It should be low volume disease, doubling time should be pretty high, performance status good, well-motivated patient, and good response to ADT. So most of these guys who come to us patients would have already had an element of ADT, and if they've got a nadir which is less than 1, I think they are candidates who will benefit. So currently we have data for radiation in a metastatic setting, but not for surgery. But I think future studies will give us that particular answer. What about metastasis-directed therapy? In a case who've already had treatment to the primary and who's recurred in only a few areas. This again is the STOMP trial. I think there's a very clear answer given here. A randomized phase 3 trial from the JCO. They've come out with their 5-year results right now. And ADT-free survival, that is without systemic treatment, it was 34% with metastasis-directed treatment, which could either be radiation, which SBRT, or it could be lymph node dissection, salvage lymph node dissection. 34% with MDT and 8% without ADT. More importantly, they looked at CRPC free survival, which was 76% with metastasis-directed treatment and 53%. This did not achieve clinical significance, statistical significance, but I think we can all look at the clinical significance of that. If somebody is able to, or some modality is able to delay the CRPC for patients, I think it's going to be a huge benefit. But is it all a true survival, or is it just the Will Rogers phenomenon? So Will Rogers is, for those of you, I also read up about him today. So he was actually an Native American actor, comedian, and his famous statement was, well, when the Okies moved to California, it actually increased the IQ of both the states, which basically what he meant was when people moved from Oklahoma to California, the guys moving from Oklahoma were of low IQ. Because California as such had a very low IQ, these guys went there and increased the IQ of California. So how do we relate it to our situation here, which is oligometastatic disease? Currently, we have, in India at least, we don't do bone scans or CT scans to diagnose metastasis. We use the PSMA PET scan. So if a patient currently has a PSMA PET scan, we're going to pick up more metastasis than we did when we just had the bone scan. So these guys would move from locally advanced to oligometastatic disease. And the PSMA PET scan can also pick up more metastasis and push people to polymetastatic disease. So in the locally advanced guys wouldn't have, if I show you the next slide, it'll be better. So the sensitivity and specificity of PSMA PET scan is around 86%, and currently it's increasing compared to bone scan as well as just CT. So you have patients who are having a lead time bias. Novel imaging is pushing more patients more into into oligometastatic category from the locally advanced category. So as such, what's happening is the guys in the locally advanced are also going to do well, and the guys in the oligometastatic are also going to do well, primarily because you have a better risk group that is coming into the oligometastatic patient population. So is it just a Will Rogers phenomena? I think time is going to tell. But currently, we can't go back to our previous imaging modalities like bone scan and CT scan. I think it's a regressive step. But if you have access to PSMA PET, that will be the best way of diagnosing them. And if the patient is an oligometastatic candidate with PSMA PET, then he can have potentially treatment that he would have had if he's a locally advanced candidate. But if he's polymetastatic on PSMA PET, that's where you have to make your own discretion, where you would look at his other clinical parameters like PSMA, Gleason score, what's his doubling time, and what's his general status, and then give him the benefit of doubt as to whether he's going to be treated as an oligometastatic patient or a polymetastatic patient. So this is what I was trying to allude to. You know, A and B are bone scans, and C is a PSMA PET scan. You know, so if it's the same patient, the amount of meds that we are able to pick up with the PSMA is much, much more. And this is probably the reason why you would have a Will-Rogers phenomena when you're talking about oligometastatic disease with current imaging modalities. So let me quickly go on to take-home messages. Treatment of primary in oligometastasis, there's definite evidence for radiation in a low volume setting. This has been given by Stampede and Horad. And potential for surgery is, current evidence is not robust. So surgery has the potential to decrease local complications, and you really need to wait results from randomized controlled trials that are already on, especially the trombone, for giving that answer. What about metastasis-directed therapy? I think the STOMP trial is evidence enough. It definitely delays the need for ADT. It delays CRPC. But questions regarding overall survival need more data. So that's where we are regarding oligometastasis. I'm happy to take questions. Thank you for this opportunity.
Thank you, Dr. Anand. So I'm collating the questions now. While I'm doing that, let me just update everybody that we have about 390 viewers from 22 countries over our different platforms. So it is going worldwide now. I think the first question that everybody's asking, of course, you've answered quite nicely that the PSMA PET is probably the ideal one that you choose. What if you didn't have the PSMA PET? Which would be your next in line? And would you consider the whole body MRI as another option?
That's a very good point. So if you don't have the PSMA PET, all of the studies that have come till now have looked at CT and the bone scan. And I don't think you need to break your head about not having a PSMA PET. You could just very well use your bone scan and CT scan to go ahead and give the patient an answer. If you do have access to a whole body MRI, I think currently the PSMA PET and the whole body MRI are more or less equal in what they can give you.
Great. Would you consider bony mets and lymph node mets the same or different?
So, previously we would, at least about 10, 15 years ago, as soon as we heard the term metastasis in prostate cancer, especially lymph node or bone, they would straight away go on to hormone treatment. But now we know for sure that there is a difference. We can give them a benefit or give them a difference. Number one is lymph nodes within the pelvis have the best outcome. Lymph nodes beyond the pelvis, again, the retroperitoneum, not as good a response. And bony mets, even worse a response when you compare to only lymph node metastasis. And the worst is visceral metastasis. Right.
So a very nice way of putting it. So regional, non-regional lymph nodes, and then bony mets, and then visceral mets. There's a question that's response to your answer. Your data shows that choline PET has a higher sensitivity compared to PSMA PET. So why not choline PET?
If you have access to it, I wouldn't say no to choline PET. But I think most of those studies that paper particularly came from UK and US, where they don't have that much experience with PSMA PET. But as it stands now, I would, if you have access to PSMA PET, that is probably the holy grail in diagnosing and staging prostate cancer.
Right. Okay. Moving on. I think there are two more questions. The first one is on focal therapy. Would you think that is an option rather than our radiotherapy for the single MET disease? Focal therapy for the prostate. Yeah.
Right. So that's a very good question, actually. We don't have enough data to give you that particular answer. But if you're treating a patient with radiation. I would want the radiation to be given to the prostate as well as the pelvic region, as well as SPRT to the metastatic entity right now. So, but focal therapy may not have the same advantages in treating the pelvic lymph node area when you're talking about a metastatic disease. So that's probably one of the reasons why I wouldn't suggest that. And that's one of the advantages of surgery as well, where you would be able to clear the prostate as well as do an extended lymphadenectomy. A focal therapy, I'm assuming you're talking about HIFU and cryo when you're talking about focal therapy.
Yep.
So that's
Yep.
one of the disadvantages of focal therapy. But then again, I don't have enough data. We don't have enough data to say no to it at present.
Sure. There's another question that's asking about the role of samarium. I think because of the role of samarium in the bony mets, would that be a consideration for oligomet disease?
So rather than samarium, we have more experience with lutetium PSMA as well as actinium PSMA. And I think that the role has to be evaluated further. And it's a very good point. You know, whether you talk about chemotherapy for soft tissue meds or lutetium PSMA or actinium PSMA, again, they all point to the same area where you're trying to reduce the amount of micrometastasis, but at the same time take care of the primary. I think we need more data to answer that question. But if you have access to samarium right now, I would say the point where we use samarium is in HRPC setting. We haven't used it, or at least I haven't used lutetium on hormone-sensitive prostate cancer yet. But I think the sequencing of these sort of theranostics is going to come more and more in front rather than at a later date in future.
Right. There's one last question here which just came up. Because the PSMA PET and the choline PET seems to be slightly different in how they pick up, would you think there's a need for a change in definition of oligomets based on PSMA versus based on choline PET?
So I think as it stands, we don't have enough data to suggest whether PSMA and oligomets have a huge difference in their pickup rates. Currently, I would say no to that particular question. You know, you may need to want to change your definition based on whether it's a bone scan or whether it's the PET scan. But within the PET scan, I don't think you need to make that much of a difference. As it is, we're talking about a heterogeneous group, and our goal is going to be to bring that group smaller and smaller. But if we try and split hairs between choline PET as well as PSMA PET, I think it defeats the purpose.
Right. So thank you very much, Dr. Anand. This is a really big topic which I think will evolve over the years. And certainly when I started, you were right, you know, one met is the same as any other met, but now not all mets are the same. So thank you very much